Senator Thune, you're next.
Thank you, Mr. Chairman. I want to thank you and Senator Hatch for holding this hearing. This is a hearing that I had written to you and requested a year ago, and I appreciate the fact that we're having a couple of hearings on what I think is a very important topic. And earlier this spring, I worked with a number of my colleagues, including some on this committee, on a white paper that explored issues I hope we address today. And I would like, if it's okay with you, Mr. Chairman, to submit it. It's called Reboot, Reexamining the Strategies Needed to Successfully Adopt Health IT. Submit it for the record.
Without objection.
And I want to start by thanking Dr. Mostashari for the efforts that he's made in responding to questions posed to the administration as part of that reboot report. We received a response last week and appreciate the substance of that response. I want to ask a question. I'm really concerned about the argument that we need to make sure that there is a sufficient business case for continued progress on interoperability and exchange of data between unaffiliated providers. At some point, the ability for the federal government to provide sufficient carrot and stick incentives is limited by the resource constraints and an appropriate level of financial penalties. So I'm curious to know what you're doing to encourage the use of real market forces, not just government incentives and penalties, to create the business case for continued progress. And I'm also interested in knowing what role the anti-kickback statute plays in constraining the types of market incentives that could be used to help make that business case.
Absolutely. And to clarify, we believe that it's important for government to be part of, along with the states, along with commercial payers and purchasers, to be part of changing the context in terms of how the market operates. We're not suggesting that we need more incentives akin to the Health IT incentive program that are incentives for, per transaction, paying people per transaction to create a business case for information exchange. It's more creating the context. The readmission adjustments have had a marked effect on hospitals' interest in coordinating care once they discharge their patients. They just have. We see that every day. The vendors now are much more interested in having interoperability because their customers are saying to them, the market is working. Their customers are saying to them, when I discharge a patient to a nursing home, I want that nursing home to be able to get this information electronically. I want the primary care provider to get the discharge summary. If someone shows up in another emergency room, I want to hear about it because I don't want them readmitted. That's what we mean by creating the business case for information exchange. It's really the business case for care coordination, which is what this committee is taking such important steps on. In terms of the Stark and anti-kickback, we worked with CMS and Department of Justice on a notice of proposed rulemaking on that, and I'll let Dr. Conway speak to that. But it was one of the clearly one of the policy issues that we could use as a lever to make sure that if information systems and software are donated, that we also get the expectation out of them that they will not be used to lock in patient data to a given institution.
Yeah, so as Dr. Mostashari said, we have a proposed regulatory change we think addresses some of those issues. Obviously, there are additional statutory changes you or other senators are interested in. We would work with you on that. I do, just to amplify what Farzad said on the incentive structure, I've worked in delivery systems that migrated their contract models away from fee-for-service to accountable care models, and it does shift your incentives in a private market setting to incentivize sharing of information, coordination of care. So whether it's a readmissions program or new payment models, our goal is to incentivize those models that enable providers in the private market to achieve better health outcomes at lower cost.
I want to come back to something that the Chairman Baucus talked about earlier. I'm concerned about the digital divide that may only get larger as rural hospitals are expected to take the leap into the more rigorous requirements of Stage 2. They've already expressed great concerns about Stage 2. I'm of the view that ONC and CMS ought to develop a way for rural hospitals to have more time to achieve Stage 2 while allowing the more advanced healthcare systems to and providers to move on to Stage 3 if they're ready. And so the question would be, will you commit to giving rural providers more time to achieve Stage 2?
We meet with the rural providers. We hear from them. Marty Faddick, who you'll hear from next week, is on our advisory group, and we have been, I think, quite open to dialogue with the rural community in terms of how we can help them achieve success and not necessarily accept that they are necessarily going to be further behind. And I think what the regional extension centers have helped now. We set a goal of getting 1,000 critical access hospitals to meaningful use by the end of 2014. We're going to revise that goal to get 1,000 critical access hospitals to meaningful use by the end of this year. We think that we are making good progress with those hospitals through the technical assistance and through the coordination that is possible. So we're open to dialogue, but I would much rather see the rural hospitals be able to keep up rather than be acknowledged that they're going to fall behind.
My time's expired, Mr. Chairman. I have a couple more questions, but I can submit them for the record.
Okay. Thank you, Senator, very much.
When you go to Montana, I think the bow tie is okay as long as you're wearing cowboy boots.
There you
That'll
go.
be the ultimate equalizer. Without beating this to death, and we've covered a lot, and I understand the aspiration you have to have all the rural providers being able to participate in this and to move along at the same rate as some of those in more urban areas, but as a practical matter, that's just a very probably unrealistic thing to hope for. And so I guess the only thing I would say is I think we need to really carefully balance accommodating those rural needs while not holding back those that are ready for a more advanced data exchange. And I guess the only thing I would say in response to your earlier response when I asked the question about whether or not you give rural providers more time, that you really do take a realistic approach to accommodating those needs, because I think, just practically speaking, the area that the chairman represents and the area that I represent are very remote, very rural, and these things are just, practically speaking, going to take a little more time. The stage one of the meaningful use required no actual cross-platform exchange of information. Stage two requires one instance of information sharing, and that can be with the dummy server set up by the government. In 2013, how is it possible to meaningfully use information technology without actually sharing information outside of a proprietary network? And so the question really is, hasn't the bar really been set too low for those who are ready for an advanced level of exchange?
We do have, I think, again, listening to the community and everybody who's affected by this, including some rural providers who said that they don't have means of exchanging information. I think the challenge that you raised is exactly right. How do we not hold back those who want to be the trailblazers and yet make accommodations for the diversity that we have in our country? The other observation that we've had with setting thresholds, Senator, is we fight a lot and have a lot of discussions about what the threshold should be. And what we actually find is that when the data comes in, when the providers actually do the workflow changes, they don't just do it for 10% or 20% or 30% of their patients. They do it consistently. And there was just a paper published this week that found that whatever the threshold was, the actual median level of accomplishment was between 92 and 100% on the part of hospitals in the threshold. So for me, one of the lessons has been to focus a little bit less on fighting over the threshold and just get folks to begin making that transition. I think the menu items, the menu optional approach was one way that we allowed for people in stage one who are ahead to get credit for information exchange use. And for stage two, we said, you know, it's now everybody has got to be able to do it. I'd love to continue to work with you and with the committee on how we can continue to keep the pressure on interoperability and care coordination while accommodating the diversity we have in our country.
In the stage three rules have not been written. And I'm wondering how we achieve those goals that you've laid out between now and the end of Stage 3 in a reasonable way. And I'm also wondering what your plans are for after Stage 3. Are you planning future stages? If so, what do those stages look like?
Maybe I'll start, and then Dr. Moshari can build on. We plan to write the Stage 3 rule in 2014. To the previous question on interoperability, we put out a request for information on how we push interoperability forward. And so we're taking that input in both for Stage 3 rulemaking and for any other changes outside of meaningful use rulemaking. So we plan to propose Stage 3 in 2014.
Okay.
In terms of the roadmap for meaningful use, I think I was just visiting Virginia Commonwealth University last week with Patrick and John Blum, and their journey is very similar, I think, to what many other providers are facing, where their first priority was making sure that within their practice, within their hospitals, all across their different sites and specialties, they can share the information and the information is available when they need it. That's kind of stage one. And that was their first priority, the first few years of their journey. The next priority for them was, okay, now how do we reach out to our affiliated providers that we work closely with all the time? How do we make sure those referrals get to them, get back and forth, the laboratory results are getting where they need to go, the EKG results are going where they need to go? That's stage two. And much of what we have in place will support that sort of local coordination of care, planned care, referral exchange, laboratory exchange, public health exchange, pharmacy exchange, the network of providers that are within your local community that you exchange information with. And for stage 3, and where they're not quite there yet, is how do I allow someone else to query my system? And there are lots of concerns that providers have before allowing that to happen. They're technical issues, but they're also issues of how do I know that you're authorized to do this query? How do I know that you're getting at the right patient? What if I release information on the wrong patient? How do I know to trust you? So those are, I think, if we look at the roadmap for how we're going in interoperability, the goal is always the same. The goal is that patient information is available when and where it's needed, but the staged approach accounts for the realities of where we are and where individual providers will be in their progression. First, let me get my own house in order. Next, let me exchange information with those I talk to all the time in my local community, and then the next stage will be enabling that, what we all hope for, that wherever we are, if we have a problem, that our information can be accessed. I will say that the other thing that stage 2 permits is this. Stage 2 permits every patient, every family member, every caregiver who chooses to accept more responsibility and be empowered with their own information to get their own information and share it with whoever they want to share it with. And I believe this is going to be a major step forward if healthcare providers also embrace that relationship, new relationship with the patient.
Thank you, Mr. Chairman.
Yep, thank you.